Good morning, everyone. And I think it's cold here, but you know, in the Houston they don't have power. So I really appreciate Doc Gong to try to drive to different places to be on these Zoom meetings. Yeah. So yeah, now it's a great pleasure and a privilege to introduce Dr. YGong from the University of Texas MD Anderson Cancer Center. Dr. Gong received her medical education in Zhejiang University in China, and then she traveled around the world, worked at least 3 continents, based on what I know. And then finally sat down in the US and did her pathology residency training in Northwestern University and the Pathology Fellowship in University of Texas. And then she stayed there and rose the third rank to the tenured professor, tenured full professor. Erin has received many honors and awards. She's very active in professional societies and organizations. She served as president of Chinese American Pathology Association from 2018 to 19 and made a lot of changes and really promote the organization that served the residents and trainees, and has started many online lectures. And Dr. Gong is very productive in translational research and has published around 140 peer-reviewed articles and several books. So today she's going to talk to us about FNA in diagnosis of metastatic disease. Welcome, Dr. Gong.
Thank you, Dr. Lee, for your invitation and a nice introduction. Good morning, everybody. It's my honor to be here to share some interesting case with you and our experience with the diagnostic strategy for FNA diagnosis of metastatic neoplasm. So this morning I have 2 talks. First is part 1 is in the grand run. It's a general outline of the strategy approach, and then part 2 is for the trainee, and mainly it's a case study. So let me just stop my video here. And the practical approach to FNA diagnosis of metastatic neoplasm. And let's go forward. Okay, so as we all know that the FNA is an important diagnostic tool to evaluate a mass lesion because this is a simple, fast, and less invasive and cost-effective procedure. Use fine needle aspiration, we can charge specimen for ancillary studies, including immunocytochemistry, flow cytometry, cytogenetics, FISH, and molecular analysis. Important things is we need to know what clinicians want to know from us. So here is a step-by-step approach. Number 1, once you get a mass lesion, fine needle aspiration material, you need to think about those questions quickly. Is this lesion non-neoplastic or neoplastic? Is it reactive as neoplastic? If it's neoplastic, whether this is a benign or malignant. This is a malignant lesion, is this a primary or metastatic tumor? If you think this is metastatic tumor, then you have to decide what is the primary site. These questions are related to clinical management. So those are the key questions I have to repeat several times during the talk and also during the interesting case conference. So keep in mind. First of all, how to approach fine needle aspiration. So how to approach the FNA diagnosis, there's 3 aspects we need to consider. First is metastatic pattern, then is morphologic pattern, and then immunopattern or ancillary study. So first of all, the metastatic pattern can be typical or atypical, can be local, regional, or distant metastases. See, there's not, okay. So it's important to remember the common metastatic patterns. For instance, if the metastatic disease appear in the liver, the first things you need to think maybe this origin is GI and pancreatic origin. If this one is in the bone or is in the larger bone, you may need to think this in the man could be prostate, in the female likely breast, those are the common metastatic scenario. And if it's in the axillary lymph node, you may think of in the female, maybe it's a breast origin. So those are the common pattern. What about the uncommon pattern? Uncommon pattern, of course, those are the metastatic pattern does not read the textbook. They can go to the weird scenario, like some lung or breast cancer goes to the kidney, and some breast carcinoma, melanoma goes to the eye, and so on. So I'm not going to go to the detail, but I'm going to show some case in the following talk. So usually the cases in the common practice that can cause diagnostic challenges are those cases with unusual metastatic pattern as well as unusual morphologic patterns. Today, I'm going to highlight some classic pattern, give you the example of the classical cases as well as some unusual cases. Just to keep in mind, we need to use multidisciplinary approach to finally reach the correct diagnosis. So first, the unusual metastatic pattern. As we already mentioned, they just go to the weird place. Like this case is morphologically is classic. It's small cell carcinoma in the left lower panel, and it goes to the colloid nodule. You can appreciate the background of colloid as well as normal follicular cells of thyroid in the right upper panel. So morphologically is classic, but metastatic pattern is unusual. Next example is also uterine leiomyosarcoma goes to the breast. That's very unusual location. Morphologically, they look like a classic high-grade sarcoma. Sarcoma usually goes to hematogenous spread and commonly goes to the lung, and this case goes to the breast. So it's an unusual metastatic pattern. And also give you an example, this is a 54-year-old woman with a 2-centimeter axillary lymph node. You can see the tumor cells as grouping tight papillary-like groups with calcification highlighted by the yellow arrows. So if you don't have the history, you think this probably likely, this is a female likely from breast, and probably micro papillary invasive breast carcinoma, right? And then high power view, you can better appreciate the calcification here. And we know this patient has no history of breast carcinoma, and the recent mammogram is also normal. So we find out the patient had a history of ovarian serous carcinoma, and this is actually a metastatic ovarian serous papillary carcinoma to the axillary lymph node. Again, morphologically, it's pretty okay for this entity, but the location is quite unusual. Cytologically, ovarian serous carcinoma can be very similar to the breast micropapillary invasive breast carcinoma, although calcification is more commonly seen in the ovarian origin. But for this case, important clue is clinical history. And another example is a 57-year-old female with a history of breast cancer. She presented to our clinic with superficial clinic with a huge growing firm thyroid mass. And by that time, aspiration, we don't know what kind of breast carcinoma this patient had. So clinically, the patient presented with progressive hoarseness and dysphagia. Laryngoscopy shows left vocal cord paralysis. All these features point to the possibility this is primary thyroid carcinoma based on the clinical and the age, patient age and female gender. This probably favor of anaplastic thyroid carcinoma. Next, CT also showed a large heterogeneous left thyroid mass extending posteriorly into esophageal groove with lateral tracheal deviation and inferiorly into upper mediastinum. Again, those features favor thyroid primary. So we got FNA in our clinic after 3 passes. Eventually, we got some fragments of like a myxoid conjoined matrix, and with some scattered cells in the background, it's very hypocellular specimen. Those matrices are magenta colored in the diff-quick, and in the pepinicular stain is pale blue. And in the background, you still can appreciate the thyroid follicular cells, benign follicular cells. So now the question is this really neoplastic or something going on weird? We have to find some, the cell which can explain what's going on in this huge mass. So we keep going with large bore needle, and finally we got those neoplastic malignant looking cells. Some are epithelioid, the others are spindle cell shaped with some kind of matrix. So now we have to pause to think what this could be. We have to think about those 4 questions initially generated. Is this a non-neoplastic or neoplastic? Of course, I think it's neoplastic, right? And then if it's neoplastic, it's benign or malignant, look like it's malignant. And then because of the atypia, then we have to think about, is this a primary or metastatic disease? For the primary in the thyroid, it's hard to imagine you have this kind of tumor, right? You go through all the primary tumor, there's no usually any entity look like morphology like this. And then we think about metastatic disease. We know the patient had a history of breast cancer, but what kind of breast cancer can show this kind of morphology? That's the next question. So we made effort to find the initial biopsy of the breast tissue, and then we found actually looks some kind of similarity to the current FNA in the thyroid. They are malignant appearing epithelioid and spindle cells embedded in the mitochondrial matrix. There's only one breast cancer, one type of cancer may show this kind of morphology, but you really needed to have immuno to prove it. Then we did cytokeratin, which is positive, and now you probably know what's the answer. This is a metaplastic breast carcinoma to the thyroid. Retrospectively review the morphologically, cytologically is okay. It's classic for this entity, but the location of metastatic is unusual. Another example is a 54-year-old female with 3.0 centimeter inguinal lymph node. So in the lymph node, usually more often seen in the carcinoma situation, right? And this one is loosely cohesive plasmacytoid cells and with eccentrically located nuclei and with some kind of matrix in the background. So with this morphology, with this location, you may be puzzling what's going on. So more aspiration, we find the material, some area shows very, very delicate vascular networks, and the tumor cells are loosely stick on the vascular networks. So it's difficult. So we have to find the history. We have to compare to the previous available material, and we have previous material. This is from this patient. It shows those kind of cores or nests of tumor cells with chondromyxoid matrix. For those familiar with soft tissue tumor, you probably already have some idea. And indeed, this is a history of extraskeletal myxoid chondrosarcoma. And for our case, is metastatic myxochondrial sarcoma to the inguinal lymph node. It's unusual metastatic pattern. Is sarcoma goes to the lymph node. So much for the metastatic pattern. Now we move on to the morphologic patterns. Morphologic pattern can further divided into lineage nonspecific and lineage specific. Lineage nonspecific meaning the tumor from different histogenesis with similar morphologic patterns. And now let's first start with lineage specific patterns. We have to think about if the tumor is poorly differentiated, if the FNA material is coming from a patient with unknown primary, the first you have to think about the 4 major categories: carcinoma, melanoma, lymphoma, or sarcoma, right? Those are the epithelial origin, melanocytic origin, or lymphocytic origin, or mesenchymal origin. Correspondingly, if you're not sure, the first line of immuno is doing pancytokeratin and MART1 and other melanoma markers, or CD45, and retrospectively. For sarcoma, there's no specific general markers. So Vimentin may be one of the consideration, but Vimentin can also be positive for carcinoma, have to keep in mind. So Among those 4 categories, carcinoma is most common. We talk about it later. Let's just quickly look at the second category, melanoma. Melanoma usually shows cellular aspiration on the FNA, and the classically picture is dispersed or discohesive arrangement tumor cells. They are plasmacytoid appearance and with prominent nucleoli and often binucleated. And you're also looking for intranuclear inclusion, which is very specific diagnostic clue for melanoma. And if you're lucky enough, you have cytoplasmic pigment. If you find the pigment, the diagnosis is straightforward, but you're not that lucky all the time. And you also need to remember, melanoma is a great mimicker. It virtually can resemble many other tumors and it can metastasize to virtually anywhere and sometimes presented as unknown primary. Those reasons can cause diagnosis very difficult, right? This is one of the example of the melanoma. Initial superficial impression is hematopoietic malignancy, like lymphoma, right? It is cohesive lymphoid. And then we know the history of melanoma, and we did corresponding markers, HMB45 and MART1, both performed on the smear. Since we don't have cell block, we sometimes perform those immunostain on the smear, as long as have internal in-house validation, we do those staining on the smear. So this is a melanoma. Melanoma sometimes can show spindle cell morphology, as you can see here. And diagnosis is straightforward for this case because there's abundant melanin pigments. Sometimes spindle cell melanoma may not show, and often, actually, based on our previous study, often they are amelanocytic. In that scenario, diagnosis could be difficult. The morphology of those spindle cell melanoma can show very bland, fibroblastic-like morphology all the way to high-grade, ugly cells resemble some high-grade sarcoma. So next entity is lymphoma or hematopoietic malignancy. During immediate assessment, it's very important for us to figure out we are dealing with epithelial origin tumor or melanocytic or lymphoid, because if it's a lymphoma, the way of specimen triage is completely different from other entities because you have to try to consider to collect enough material for flow cytometry or maybe for flow. So how to recognize the lymphoid feature? First of all, they are usually single cell pattern, dispersed single cell pattern. And also, they usually show blue cytoplasmic rimming, like here. And also, if cytoplasmic have detached and just in the background, detached cytoplasm, we call lymphoglandular bodies. Those are the important clue for lymphoid cells. And also, if it's a B cell, mature B cell lymphoma, they tend to show coarse chromatin pattern, unless you're dealing with lymphoblastic lymphoma or some blastic variant of like mantle cell lymphoma. Maybe they are not coarse, but majority of mature B cell lymphoma, they have coarse chromatin pattern. And the features of blue cytoplasmic rimming and lymphoglandular bodies is readily seen in the diff-quick stain slides, and coarse chromatin pattern is better seen in the perpendicular stain slides. Differential diagnosis includes small blue cell tumors as well as lymphoma, as we just give you example before. So once you know you are dealing with a lymphoma, you need to figure out the next question: is this non-Hodgkin lymphoma or Hodgkin lymphoma? Because the specimen triage is also different among these two entities, right? If this morphologically suggestive of non-Hodgkin lymphoma, or between the differential diagnosis of reactive lymph node or non-Hodgkin lymphoma, you need to consider priority is collect sample for flow. Or if you have more material, you can use cytospin and put it in the tumor bank -80 for potential flow, potential FISH study. If the sample is severely crushed or not enough cellularity for flow, you can actually do cytospin and stain kappa and lambda to figure out which one is predominantly increased, to figure out whether this is a clonality. In this case, the lambda is way too much than the kappa, and this is lambda clonality. If the lesion shows some features suggestive of Hodgkin lymphoma, such as this kind of morphology, Riestenberg cells binucleated, and then there's a background of neutrophils, eels, and maybe plasma cells, suggest a Hodgkin lymphoma, then you need to collect a sample for cell block, or you ask for core needle biopsy, because flow is not going to help. Flow is not the priority for you to consider, and you need to, do the tissue. If you don't know, you're not sure you're dealing with Hodgkin or non-Hodgkin, then you try to collect something for flow and other tissue for tissue diagnosis, like a core biopsy or cell block. Importantly to remember, if it's the first time diagnosis for lymphoma, there's no history of lymphoma, and this is a specimen suspicious for lymphoma, regardless of Hodgkin or non-Hodgkin, you need to ask for core biopsy for tissue confirmation. Okay, so the next entity is sarcoma. Sarcoma usually show atypical spindle-shaped or pleomorphic cells, and the diagnosis usually is straightforward. Previous history is usually available because sarcoma usually grow very large. Just some example, they tend to show spindle-shaped, like a peripheral nerve sheath tumor, like you can see here. And then some can be pleomorphic and rhabdoid, like this rhabdomyosarcoma. And also, this one shows pleomorphic and epithelioid, and we know the history of epithelial angiosarcoma and metastatic to the calf soft tissue. Indeed, it looks like epithelioid. If you still have doubt, you need to do immunostain. For this case, immunostain CD31 is performed on smears, which is positive to confirm it. Another case is a 54-year-old female with 0.8 centimeter nodule in the popliteal fossa. The overall cellularity is pretty high, and the majority cells shows epithelioid or some kind of plasmacytoid cells, occasional spindle cells. So it's kind of puzzling. This is dealing with melanoma or some kind of epithelioid neoplasm. We know the history of undifferentiated sarcoma 10 years ago. We pulled the previous tissue section to compare. There's a similarity, but we still doubt whether our samples truly represent a sarcoma. So we did cytokeratin and MART1, both negative to rule out the carcinoma and the melanoma. Vimentin is diffusely strongly positive to confirm this is indeed metastatic unclassified sarcoma. So we mentioned the carcinoma is the most common C entity, and its hallmark is pancytokeratin diffusely and strongly positive. So usually after the first tier of immunostain, you know it's carcinoma, then you need to know what is the subtype. You're not just saying malignant cells present, period, or carcinoma, period. You need to try to subclassify whether this is adenocarcinoma, squamous carcinoma, or neuroendocrine carcinoma, or many other like urothelial carcinoma, renal cell carcinoma, hepatocellular carcinoma, and so on. So each carcinoma have corresponding primary origin. I'm not going to go to the detail. Among those subtypes, adenocarcinoma is most common. We'll talk about it later. First, we just move on to the squamous cell carcinoma. Squamous cell carcinoma, if keratinized, diagnosis is straightforward, right? For the first year resident and training for maybe 1 month, they're easy to make a diagnosis, keratinized squamous carcinoma. But if carcinoma is moderate or poorly differentiated, like this right upper panel, the diagnosis could be puzzling. Other polydifferential carcinoma or even small cell carcinoma enter the differential diagnosis. So the diagnostic clue for squamous carcinoma is, first of all, they are haphazardly piling together. There's no glandular differentiation. It's not adenocarcinoma, no glandular differentiation. And they have some kind of extensive necrosis in the background. Of course, any polydifferent carcinoma can extensive necrosis, but more commonly seen in the squamous carcinoma. They have very dense cytoplasm and pyknotic or smudging chromatin pattern. Those are the features for polydifferential carcinoma, squamous carcinoma. And also, sometimes they show spindle cell morphology, which can be one of the pitfalls, like you see in the lower panel. So polydifferential squamous cell carcinoma, because sometimes they can show scant cytoplasm, high NC ratio, therefore they can molding together, resemble small cell carcinoma. So in that scenario, you needed to do some staining. Neuroendocrine marker will be negative, and the squamous cell carcinoma like P40, CK56 will be positive to confirm the diagnosis. Now we move on to neuroendocrine carcinoma. Just one example. This is a 64-year-old male with a 2-centimeter lytic lesion in the vertebral bone. So morphologically, hypercellular smear shows plasmacytoid cells with eccentrically located nuclei and binucleated cells. So superficially resemble some plasmacytoid cells. And with patient age is old, male, and the lytic lesion in the bone, you may think about myeloma, right? Easily have this kind of consideration. However, we know this patient have history of neuroendocrine carcinoma. We did chromogranin in one of the smear and shows positivity to confirm this is metastatic neuroendocrine carcinoma. Retrospectively, the features supporting neuroendocrine is their fine chromatin, salt and pepper kind of chromatin pattern. There's no like clock-faced chromatin there that is usually seen in the plasma cell neoplasm. And also you don't see perinuclear half that is usually features for plasma cells. So those are the things you needed to consider. So the next entity, the other tumors, so we just give one example of urothelial carcinoma metastatic to the retroperitoneum, and the morphological pattern is okay because they have some kind of polydifferentiated cell nature, single cell pattern, and plasmacytoid and Sakari-form tail cell tails, which is features for urothelial carcinoma. And also the metastatic pattern is also okay. Retroperitoneal is a place where urothelial carcinoma is commonly go. Because of the time, sake for time, we're not going to go more and just jump back to the most common entity, which is adenocarcinoma. So when we're dealing with adenocarcinoma, we have to think about what are the common patterns of adenocarcinoma. There's 5 common patterns. First is glandular features, and second is papillary features, and the microacinar features, and mucinous features, and signaling cell features. So each one has corresponding primary site. First of all, adenocarcinoma, this is a glandular pattern. Why is glandular? Because you can actually appreciate the flat sheets of tumor cells with columnar cells palisading around the luminal edge. This is a sharp luminal edge. You can imagine there's a lumen in this area. So this is glandular. But sometimes they don't show obvious glandular structure, but you can see flat sheets of cells with foaming cytoplasm, suggestive of adenocarcinoma, and the chromatin usually open with prominent nucleoli. Sometimes they contain mucin. If you are not sure whether mucin present or not, you can do mucin calming, which is positive to confirm this is adenocarcinoma. The second pattern is microacinar, which can be seen in the thyroid, prostate, and so on. This is an example of microacinar pattern of prostate carcinoma. Morphologically, acinar, very classic, probably is originally Gleason score 3+3, and the cell block also show corresponding 3+3 morphology with cribriform features. I'm going to give you one of the interesting case. This is an 85-year-old male without history of malignancy. He presented with a large pelvic mass that destroyed acetabular bone, adjacent bone. It's a huge mass. Patient had a history of BPH with total prostatectomy 30 years ago. So we had fine needle aspiration on this acetabular bone large mass. This is a smear, very cellular, and monolayer sheets, cohesive. So looks very, very bland, right? High power view again shows monolayer sheet cells, and there's no any certain, acinar structure. Basically it's monolayer sheets. Cells are quite uniform, bland, or we can say that way, bland. So when we get this smear, we are kind of like thinking what's going on. And my fellow actually raised a question whether this could be incidentally sampled benign GI epithelium. I think this is a reasonable consideration. Why not? But this is just kind of like too much, right? It's too much, too cellular. And also, this is a large mass. I don't believe radiologist needle will miss this large mass. Therefore, we try our effort to find any features support neoplastic process. And indeed, we find, although monolayered, there's a cell polymorphism. Some cells are small, nuclei smaller than the others, maybe 3-4 times bigger than the others, like this bigger one, and some are small one. And also there's some nuclear overlapping, lost the nuclear plurality. There's overlapping and disarray. And also you can appreciate some mitotic figures. Now we know we're dealing with neoplastic process. The needle is indeed aspirate some neoplastic cells. Next question is, what are those tumor cells? And we wait for cell block to come and shows tubular or glandular structure. We lined by columnar cells, and there's a nuclear palisading with lumen. So this is adenocarcinoma, right? So when we have adenocarcinoma in the acetabular bone, we have to think about what is the primary origin for this patient, this male patient. Then we bring up the differential diagnosis, including adenocarcinoma of colorectal origin, could be pancreatic, could be lung, could be urinary bladder. Those arising from Bruch's nest or cystitis glandularis can show adenocarcinoma, right? Urothelial bladder, if the tumor arising from urethral remnants, they can show adenocarcinoma. Lastly, we put prostate carcinoma in the end, although there's prostatectomy for BPH 30 years ago. Because of the morphology, we just put on here to see what's going on. And we have to do immunostain, right? The immunostain have big panel. First of all, CK7, 20, and TTF1 villine, all negative. At that time, we don't have CDX2, we don't have other markers, but those markers negative, basically the lung and the colorectal is not possible. And then we do PSA and PAP, which are diffusely strongly positive, although very surprising, but this is truly support this is prostate origin. And we consult to the GU pathologist and confirm this is metastatic prostate carcinoma. It's also called endometrioid type or large ductal type. So what's going on with this patient? We really don't know. Maybe BPH during prostatectomy still have some kind of peripheral prostate tissue left and then develop with this kind of large ductal carcinoma later on. That's possible. And the clinician subsequently ran the serum PSA test, and the level is sky high, more than 1,000. So another thing I want to emphasize, sometimes carcinoma, which is not classic adenocarcinoma, can show the acinar, microacinar features. Like here, you can see hepatocellular carcinoma shows microacinar features in the cell block, Also, the tubular microacinar features classical for HCC with endothelial rimming, right? It's very nicely. So keep in mind that they are not always adenocarcinoma. And another example is pheochromocytoma or periganglioma can show those kind of microacinar features. And this case actually initially misdiagnosed with adenocarcinoma. And this needed to keep in mind. So now the mucinous features can occur in various tumors like breast, ovarian, and so on. So just a quick example, this is a metastatic IPMN shows abundant intracytoplasmic mucin. Because they reach mucin in the cytoplasm, the cell borders is very distinct because the cells are squeezed to each other. There's some background mucin. Sometimes you can see, but may not be seen all the time, but definitely you will see intracytoplasmic mucin. Another example of the mucinous is a colloid carcinoma of the breast, metastatic to the lymph node. Original carcinoma in the right panel, and the left one is metastatic carcinoma to the lymph node. This tumor is indolent, usually not metastatic, but sometimes can occur. So papillary features can be seen in many different types of tumors. Here's an example, is a papillary renal cell carcinoma to the retroperitoneal lymph node. They are classic morphology and classic metastatic pattern with papillary features and fibrovascular course, low power view and high power view. It's classic case. And sometimes you may see invasive micropapillary breast carcinoma to the lymph node. This entity is very aggressive, tended to be metastasis to the lymph node or to many distant organs in the early time. It's easy to to have worse prognosis. So this is the left panel is metastasis in the lymph node. The right panel is the original histology showing those empty space embedded with tumors. Those tumors, the empty space is not a lymphoid space because there's no endothelial cells. So this is another papillary features tumor, 64-year-old female with 4 centimeter peritoneal mass. The mass is attached to the liver. And as you can see, there's abundant papillary groups with fibrovascular cores. It's 3-dimensional cell groups, very difficult to evaluate. So we move on to the edge of the slide to find those monolayer sheets of cells superficially resemble some kind of pelvic washing specimen in the cytology. So those are the features. So you have to ask yourself what's going on. We have to wait cell block to come. And the cell block shows broad papillary fronts lined by flat or cuboidal cells with hyalinized fibrovascular cores, and some shows filled with forming histiocytes. So the question is, what are this mass or tumor which attach to the liver in the peritoneum? So we have broad differential diagnosis. We consider some kind of weird carcinoma or even weird vascular tumors. However, BIEP4, MOX31, CD34 or negative. And then we add the mesothelial markers, TTF1 carotene, both are positive to confirm this is well-differentiated papillary mesothelioma. So this is the entity not commonly seen, usually occurred in the middle-aged woman and is not associated with asbestosis exposure. To confirm this, at that time, we still do some kind of EM. That is probably 20 years ago. We did an EM and shows abundant slender microvilla on the cell surface to confirm this is indeed mesothelial origin. So one thing I want to emphasize, sometimes the tumor which are enriched in the vascular networks, like in the right panel, they don't have papillary features. Because of the rich in vascular network, the smear can give rise to the impression which resemble papillary architecture, as seen in this extraadrenal periganglioma. So this was initially misdiagnosed as papillary adenocarcinoma, but in reality, there's no papillary structure. This is just a solid vascular periganglioma. So keep in mind, this is just a tissue fragment, not papillary structure. So next one is signaling cell, can be seen in the tumor from stomach, breast, or pancreas, okay? So give you some example. This is inguinal lymph node with history of signaling cell carcinoma from anus. And of course, the diagnosis for this case is easy because this lymph node shows some features which not belong to the lymph node, so must be metastases. And already know the history of signaling cell, so this is metastatic signaling cell carcinoma, period. However, if signaling cell carcinoma appeared in the ascites fluid, the diagnosis can be difficult because some mesothelial, degenerated mesothelial cells can have cytoplasmic vacuoles resemble signaling cells. So you are not sure this is truly metastasis or this is degenerated mesothelial cells. So this one, we have to look for features that is dense chromatin pattern, very hyperchromasia, and also the mucin droplets, as you can see here, mucin droplets. This is the atypical nuclear features and the hyperchromasia, like here. If you're not sure, you can do the mucin positivity will confirm this is truly mucin-containing signaling cells. Sometimes the tumor, which is not adenocarcinoma, may give rise some signaling cell features. And this is example, I just recently encountered a metastatic melanoma with signaling cell features. You can appreciate a lot of signaling cells here, right? So as I said, melanoma can mimic virtually any kind of tumor type. So this is one of the examples you have to be careful. For this case, SOX10 is positive to confirm this indeed a melanoma signaling cell features. So now we move on to lineage and nonspecific pattern. As I mentioned, lineage and nonspecific meaning those tumor cells with different histogenesis show similar morphological features. They can show epithelioid, they can show spindle cell, small cell, or pleomorphic, or oncocytic, or clear cell, or signaling cells. So those are the features. Actually, this talk, including this table, has been included in my book, which published 4 years ago. I think it's still practical and useful. If you are interested, you can look up some features and the diagnostic strategy from this book. So now we look at the spindle cell features, can show mostly is sarcoma, right? Can also spindle cell carcinoma and the neuroendocrine tumors and so on. Now let's see. This is a synovial sarcoma, metastatic to the lung. Metastatic pattern is classic, morphological is classic. This is sarcoma, this is spindle cell, so everything's okay. And this is metastatic just to the liver. And also metastatic pattern is classic, morphology is also spindle cell. And this is another one. This is spindle cell tumor in the lymph node. So usually we mentioned before, lymph node usually received carcinoma is more common, right? And the carcinoma usually don't show spindle cells, but spindle cell can be seen in a carcinoma. For this case, we have to think about the possibility of spindle cell carcinoma because it's in the lymph node and the supracrinal and maybe from lung. And we got cell block. They are spindle, but they are quite cohesive, indicating this could be epithelial in origin, could be carcinoma rather than sarcoma, right? To confirm this, we did pancytokeratin positive, P40 positive. So indeed, this is a metastatic spindle cell squamous carcinoma. And as mentioned, the neuroendocrine carcinoma sometimes can also be spindle cell, like here, and nicely show salt and pepper chromatin pattern, right? It's very nice, and I want to share with you here. Sometimes other tumors can also show spindle cell morphology. This is a 1.2 centimeter lymph node and a history of melanoma. Initially, we look at the left panel, pepinicular stain, so bland, those spindle cells look like fibroblastic proliferation. And we know patient had a history of melanoma. We don't know at that time what type, and we just did S100 on one of the smear. It is positive, you can appreciate. So this indeed is metastatic spindle cell melanoma. So another cell morphology is clear cell that can be seen in many different entities, especially renal cell carcinoma and ovarian carcinoma. This can show features of clear cell features. Give you some example. This is a renal cell carcinoma clear cell type. Classic morphology, polygonal cells with a moderate amount of cytoplasm, clear cytoplasm, and it's classic. And this entity, hepatocellular carcinoma with clear cell variant, is not very commonly seen, and I'd like to share with you here. The smear diff-quick shows bubbly cytoplasm, which may be because of the lipid and glycogen rich material. And in the cell block, you can still appreciate the wide trabecular pattern with endothelial cells wrapping around those trabeculous structures. So this is a clear cell HCC. So another thing we have to keep in mind is the clinical history, of course, is important. You know, the previous history of malignancy is helpful for the current diagnosis, but sometimes you may encounter some new primary as well, especially if you're working in a cancer center. It's not unusual you can see the patient with multiple different primaries. So you have to consider if the cytological features, clinical and radiological feature is not a match, you have to think about the other possibility. This is a 77-year-old male with 2 centimeter retroperitoneal lymph node. He has previous history of renal cell prostate carcinoma as well as urothelial carcinoma, grade 2. Now the FNA was performed in this retroperitoneal lymph node. Aspiration shows cellular smear, very tight clusters with maybe a little bit papillary or tissue fragments. It's very thick, so we have to move to the edge of the slide to appreciate individual tumor cells. They are foaming, bubbly cytoplasm, moderate in amount, and looks like, could be some kind of clear cell features, but it's hard to tell, right? Is this morphology fit to prostate carcinoma, fit to urothelial carcinoma? Maybe, may not be. Someone may know prostate carcinoma can have foaming cells, foaming cytoplasm, but you have to think out of the box, other possibility. So is this truly metastatic prostate carcinoma, or is really metastatic urothelial carcinoma, or this is metastatic something from third primary? So we wait cell block to come in for the further evaluation. And this area, you can appreciate the organoid nests with clear cytoplasm, tumor cells with clear cytoplasm and endothelial cells. And now you probably already know what I'm talking about. And this maybe raise a possibility this could be renal cell carcinoma, but we don't know patient have this history, and recent chart does not mention this. And we did CD10 at that time, because that time we don't have RCC, we don't have PAX8. CD10 is diffusely strongly positive, and morphologically it's matched to renal cell carcinoma. So we call this metastatic renal cell carcinoma. This is a third primary. It's bad news for the patient, but on the other hand, patient may receive corresponding appropriate treatment. When we talk to clinicians about this diagnosis, they are kind of surprised, and then did a CT. Subsequently, they do find a 2-centimeter renal mass, which is turned out to be renal cell carcinoma. So I have a wrap-up slides here. So the general principle in fine needle aspiration approach to metastatic tumors, step by step. First, if you want to call a tumor is metastatic, you have to find the cells alien to the site. If this is a lymph node, you have to see, okay, those cells not belong to this site. And if it's not a lymph node, if it's an organ like in the liver or lung, those cells may be difficult to decide it's primary or metastatic, especially they have their own adenocarcinoma. Lung have the primary lung adenocarcinoma, liver have cholangiocarcinoma. So then you have to do something else. So basically you have to ask, is this really belong to the site? If it's alien to the site, this is metastasis. And then you have to think about metastatic pattern as well as morphologic pattern. And the clinical history of previous malignancy is important, but we have to think about sometimes the other possibility, new primary. And also we needed to correlate with radiologic findings, but radiologic findings may not always correct. Like we have metastatic breast, metaplastic carcinoma to the thyroid, radiologically is just mentioned, this look like primary anaplastic carcinoma. So if nothing really matched well, you have to try to review and compare with previous cytology or histology slides to see whether they are identical or different. And in selected case, you needed to do ancillary studies. And if you still cannot solve the problem, you needed to ask for tissue confirmation, histology confirmation before definitive diagnosis. So I think I'm give enough time for further discussion, and thank you for your attention. This is a picture I took 3 years ago in Kenya. Just want to mention, we have to keep alert. We have to be cautious, to look at surroundings. If there's anything pitfall, any dangerous, we have to, do things correspondingly. Thank you for your attention. Any questions?
Thank you, Dr. Gong, for this interesting case. I think anyone has questions can either type in, so Amy can monitor it, or you can just unmute yourself and just ask questions.
I will ask a question. Thank you very much, Yun. I mean, this was a great presentation and an excellent review of major problems with the FNAs. I'm really glad that you touched toward the end on those cases where the history of malignancy itself is actually misleading.
Right.
And in your experience, about how, as a percentage, in how many cases do you actually experience that? My feeling is that probably those cases are around 5% or so of the total. I mean, it should be less than 10%.
Yeah, I don't have that percentage, but in my experience, the more you dig into the history and the clinical scenario, the better your performance, and the lower chance to make erroneous diagnosis. But indeed, those kind of things, those kind of cases can happen, can be encountered regardless how experienced you are and how knowledgeable you are. I appreciate your question, but yeah, That's why I highlighted the importance of multidisciplinary approach. It's very important. Thank you. Any other questions?
I will ask another question because nobody else is courageous enough, looks like. So, Yun, in your experience, we all know that actually we don't stop with only the diagnosis and some immunohistochemistry confirmation. We have to move to molecular testing. Mm-hmm. And that varies, the experience getting enough tissue for molecular testing is probably quite different among different institutions. So in your case, in your situation, and based on your experience, in how many cases do you actually obtain adequate material for testing, for molecular testing in these cases?
I think we usually, in the immediate assessment, if this patient has a possible primary lung, we immediately tell radiologists this likely we will have subsequent molecular study. You need to give us more material, not only enough smears, we need to have cell block. So we kind of proactively approach this kind of situation. So in our experience, the molecular testing on cytology is very frequent. Not only cell block, if cell block is not enough, we are able to use smear, either diff-quick or perpendicular smear for just scraping the tissue for molecular next generation sequencing. The success rate is comparable to cell block. It's very good. And if the patient, another example, if patient had a history of breast cancer, which has been diagnosed half a year or even one year before, the likelihood that the clinician want to repeat the biomarkers, ER/PR, HER2 on the metastatic side is pretty high. So we will ask material ahead, just for possible biomarker study later on. So usually not a problem. And we also have validation study for ER/PR, HER2 on smears, in-house validation. So if we don't have tissue section, we don't have cell block, we're still able to do those biomarkers. So we are pretty good on this aspect. Yeah.
Thank you. Thank you, Yun.
This is Andy Nelson. I'm actually the molecular pathologist. And just out of curiosity, when you guys are using the smears, what's your guys' policy on digital pathology for archiving those smears before you sacrifice them for molecular pathology? Do you guys routinely have all of your smears, your FNA smear slides digitally archived?
Yeah, digiting pathology, this part is more like widely used in the tissue histology part. And in cytology, unless this is a very interesting case, we scan the material to the system. Right now, it's still only small portion of the cytology specimen was scanned into the system. So in case we have to do molecular study on the limited cytology specimen, we have to sacrifice that when we may take pictures, but it's not uncommon. It's not common for this kind of situation. Most cases we have enough material. We have material. If not, we have corresponding. Now more and more cases have some kind of corresponding or subsequent corneal biopsy material to back us up.
Yeah, thank you.
Thank you.
Okay, I think we're going to wrap it up. We have our 9 a.m. meeting, the quality meeting with Dr. Colleen and Dr. Linden. So thank you very much for joining us this morning. Thank you, Dr. Gong. And
thank you for having me. And the interesting case conference is also relevant to this lecture. So anyone interested for this lecture and want to have expanded information can join us in the 10 o'clock hour. Yes.